Yeah, excellent. May we start?
Perfect, thank you.
Bismillah ar-Rahman ar-Rahim. It's a great honor to be with us tonight. Three eminent professors and eminent stars in orthopedic surgery from all over the world. The first presentation will be by Mr. A Unnithan from UK. He will speak about hip dislocation. Then another presentation by Major General Professor Raouf Al-Abbasi will speak about fracture of the neck of the femur. And then our dear beloved professor, Professor Baha Korana Al-Azhar University will speak about fracture of the femoral head. We will start with the presentation of Mr. A Unnithan from UK. Thank you so much for accepting our invitation and for joining us tonight, sir. May you start, please, sir?
Thank you. Thank you very much for inviting me to your talk. It's a pleasure to be here. It's Christmas here. And
Merry Christmas, sir.
And Merry Christmas to everybody. And thank you for Mo Imam for letting me know about this great opportunity to talk. Okay, can I start?
Yes, sir, please.
So hip dislocation comes with a significant force, and normally it occurs as a result of a fracture or because of trauma. So my primary aim today is to talk about virgin hips, but I am more than happy to take any questions about hips which are dislocated from a hip replacement. As a matter of fact, majority of my work is around dislocated hips from a hip replacement. I am a trauma and elective surgeon. 50% of my work is from virgin hips, and 50% of my work is from dislocated hips. So just to go through something about the anatomy of the hip, as we know, 2/3 of the hip replacement is the femoral, 2/3 of the smear, and the acetabulum is a U-shaped articular surface. But the most important thing is the ligamentum teres, which supplies the blood supply for the femoral head. Now, the important thing which is important here is to know that 40% of the femoral head is in contact with the acetabular articular surface, and 10% of the femoral head is in contact with the labrum. Now, if you do anatomy or a dissection of the femoral head, you can see that the labrum is a strong fibrous ring, which increases the articular surface of the femoral head, and which gives the hip joint its stability. Now, if you look at the anteversion of the hip, about it's an average of 7% in a Caucasian female, and in a male, it comes to about 14%. Now, I am talking in terms of majoritively in terms of when you are asked a question in the FRCS or, as a matter of fact, in real life. And the most of the questions are asked about the femoral head from the blood supply. And the blood supply, majority of that comes from the ligamentum teres. And as it continues, as we all know, it is mostly in children. And as the age goes by, the ligamentum teres blood supply from elderly decreases. Now, one thing which is quite important to understand is the blood supply of the femoral head from the ascending cervical branch, which penetrates the capsule near the femoral attachment and ascends along the neck. And this perforating branch is highly susceptible when you have a hip dislocation. And this is the vessel which, when you make a neck cut, you normally protect by putting a talon or a blunt home in, and you have to appreciate that this foot is the most susceptible in injury in terms of a hip dislocation. Now, one has to always think about the sciatic nerve. And the sciatic nerve, so whenever I have a hip dislocation, a primary or from a hip replacement dislocation, I always worry about the sciatic nerve. And the sciatic nerve is the first thing which I would check whether it is affected or not affected. Because if the sciatic nerve is not affected, you have time to work on. If the sciatic nerve is affected, okay, you have very less time to work on. And one has to always appreciate the peroneal and the tibial component of the sciatic nerve, okay, because that comes slightly laterally compared to the other nerves, the other origin of it. Now, the majority of the posterior dislocation of a virgin hip comes from a high energy trauma. Now, in my practice, about 20 to 30% of the virgin hip dislocations comes from an elderly population, and the elderly population doesn't have to be a high energy trauma. It could be just from a fall from a standing height. As a matter of fact, the last 5 hip dislocations in a virgin hip I have seen are not big trauma, but fall from a height or fall from standing height in elderly population. So one has to always appreciate that a hip dislocation of a virgin hip is not mainly from a massive trauma. But if you're looking at a young patient, the hip dislocation is mainly coming from a high energy trauma. Now, this is what one would see. That is an axial load when the load is applied of the femur when the hip is flexed. And most commonly, this occurs as an impact of the dashboard on the knee. Now, types of posterior dislocation depends upon the direction of the applied force, the position of the hip, and the strength of the patient's bone. Now, I'm talking about a young patient. This is quite irrelevant when you talk about an elderly patient. Now, the effect of the dislocation on the femoral head circulation. So this is the most important thing. So what do we worry about when you have a posterior hip dislocation? You're mostly worried about a vascular necrosis of the femoral head at the time of injury, and also how does it progress with time. This is what you will see when you see a patient in A&E or casualty. That is, most of them, the time, the leg is in forced abduction and external rotation of the hip. The anterior capsule is torn or avulsed. What are the effects of the femoral head dislocation on the femoral head? So, as I previously said, injury to the ascending cervical branch is associated with the damage to the capsule during dislocation, and this also affects because the ligament teres is affected. It also affects with other probabilities that occurs with the hip dislocation. It's very important to early identify that and relocate the hip, improve the blood flow to the femoral head. And there are numerous studies to show what are the associated injuries that occurs as a result of hip dislocation. Now, you will see majority of young hip that dislocates, and I keep on saying young hip because in an elderly population, the energy associated with hip dislocation is not massive, and this could occur secondary to a fall from a standing height, as if the legs have split, like a split of the hip, and cause a similar dislocation of the hip. And as a matter of fact, this is what the last one I saw a couple of weeks ago. And in a young hip, this is what you would see, a mechanism of a knee injury to the dashboard, which causes patellar fracture, foot fracture if the knee is extended. Now, associated knee injury occurs in 25% of patients with knee injury. It could be anything from knee injury, patellar fracture, knee dislocation, patellar tendon rupture. But the point here is that when you have a hip dislocation, you should do an ATLS, structured approach to the patient, do a primary survey, a secondary survey, and a tertiary survey. You might save the patient by reducing the hip, but if the patient has got a patellar tendon injury, which you have missed, probably will at the end, and I have had a few occasions where patients have come back and sued the trust or the hospital because we have missed something. It is vital that we do a secondary survey and a tertiary survey to find any another sort of injury. Now, associated injury, as I said to you before, the sciatic nerve is the most important thing to check. Apart from the blood supply, and there's about 10% chance that you can have a sciatic nerve injury associated with a hip dislocation. If you have a sciatic nerve injury with a hip dislocation, the time is ticking, and it's crucial to make necessary steps to decrease the neuropraxia. Majority of the time is neuropraxia of the sciatic nerve, and it's very important to work within the time limit to decrease the pressure on the nerve, as if you notice that there is neuropraxia. And from a documentation point of view, it is crucial that one always make sure the sciatic nerve is working. So the first thing, if somebody calls me from the middle of the night, my registrar calls me and said there's a hip dislocation, automatically in my brain, the first thing I ask is the sciatic nerve working? And all of you should have the same concept. Ask, is the sciatic nerve working? What is the secondary survey? What does the tertiary survey show? So the classification of the hip dislocations. Now, this is important to know the Thompson-Epstein classification. One is type 1 is a pure dislocation with a posterior wall fragment, dislocation with a large posterior wall fragment, dislocation with a comminuted posterior wall fragment, dislocation with an acetabular flow, and dislocation with the femoral head fracture. In my personal opinion, I always worry about the 4th and the 5th. In orthopedics, we are very fortunate to have 4 or 5 in every classification. Anybody asks you in the exam, describe to me the classification, always any classification say 4 or 5. You're lucky. Either 4 or 5 always works, and the 4th and the 5th is always the worst one. But in practicality, I start really worrying when I reach, when somebody says that there's an acetabular flow fracture or there is dislocation with the femoral head. The similar is the Epstein classification of the anterior hip dislocation, slightly different, but altogether it is pretty much the similar. Now, AO classification is anterior hip dislocation, posterior hip dislocation, or the obturator anteroinferior dislocation. Now, the most important thing is to evaluate the history and ascertain what are the other injuries associated with it, including the fact about whether the patient is alert and so on and so forth. Now, this is what you will classically find in a posterior hip dislocation, where the hip is flexed and internally rotated and adapted. Now, this is what you will see in an anterior hip dislocation, as I have previously suggested. Now, sometimes you could have a femoral head or a neck fracture or a shaft fracture. So it is quite important, as we previously suggested, to do a primary and a secondary survey, find out what are the other fractures associated with it. So it is very normal for us as orthopedic surgeons to go gung-ho on the hip. But the most important thing is make sure that we do a thorough primary survey. Airway takes the first course, yeah, A, B, C, D. And please intervene when you're asked to intervene and work as a team. The primary problem arises is that if we go with like I have got a hip dislocation, that is what I am going to sort out the patient. The patient might have an associated chest infection, a pneumothorax, a tracheal shift, head injury, and if we do not control that and go focus on the hip, okay, it might cause us problems. Always document what you have seen at the beginning. Now, as previous, sorry, I keep on coming back to the ATLS. I'm an ATLS instructor, and I'm quite passionate about the fact that we should always treat patients as in totality and not just the femoral and just not the hip dislocation. Okay, and always provide enough information to proceed with a closed reduction. Now, the first and foremost is to obtain an X-ray. Okay, and in this day and age, majority of the times we will have a head, we will have a neck, a chest, and a pelvic CT scan as a part of the trauma series, and hence we would be able to find any associated injuries associated with it. Now, we are sticking to the X-ray because it's easy to show the X-ray. The X-rays, Judith views of the pelvis is quite good. I do that often, but in the present day and age, sometimes it's very difficult to do Judith views, and I normally stick to CT scan, which is much more easier to do, and 3D reconstructions. Now, when you have a CT, you're primarily looking at what, obviously the dislocation, whether there is a neck femur fracture, whether there is femoral head fracture, and size of the bony fragments is quite crucial. The MRI, where does the MRI comes into play? So I normally, as a routine practice, take an MRI of the femoral head after the hip is reduced. So this is, I'm not suggesting we do it before the hip is reduced. After the hip is reduced, document what is the AVN of the hip. And it is essential as time goes by, so one of the most important worries once you have reduced the femoral head is vascular necrosis of the femoral head. And in my opinion, it is important that you have an MRI scan before and after, because when the patient comes back to the clinic in 6 months' time, 6 weeks, I normally take an MRI, look at the AVN, if there is AVN. It is important for me to compare previous to the post, see how it goes. It is not essential to have an MRI scan, because this is when the patient has a virgin hip dislocation, you're primarily concerned about associated fractures and how to treat the patient. The most important thing is an X-ray, a primary survey, secondary survey, and a CT scan. And the goal, as we suggested previously, is to reduce the hip, prevent AVN. Now, the important thing here is to require proper anesthetic. Now, this is where ATLS comes into law. A hip joint is difficult to dislocate. So you would require adequate anesthetics plus a good muscle relaxant. To get muscle relaxant, the anesthetist has to be happy the patient hasn't got a pneumothorax or any other causes like head injury where the subdural pressures are affected when they anesthetize the patients. So there is some controversy in the literature in the appropriate time of reduction, but majority of the universal agreement is earlier, sooner, the better. Now, anesthetics, as we suggested, we need to have a good muscle relaxant effect and general anesthetics. So sometimes I have done this in accident and emergency. Sometimes I have done this in theater. Always theater is better because the patient is better anesthetized. You have intraoperative X-rays, look at it. And second, the most important thing is once you have reduced the hip, you know that how stable the hip is to see whether you need to intervene or not. But sometimes in my practice, the theaters are working. So in the UK, in a district general hospital or a secondary care center, so whether it's a secondary care or a tertiary care in UK, so I work in between secondary and tertiary care, you only have one theater working 24/7. So if you have, for example, an abdominal aortic aneurysm or a laparotomy going in theater, which has just started, you might not have the time to wait for 2 or 3 hours for reducing hip dislocation. In that particular event, I have advised my registrars or I have gone to A&E to reduce the hip to save time. The problem in that process is that you would not be, in UK practice, it is unable, we are unable, we don't have live stream X-ray. So you have to take the patient back to the A&E, sorry, to the radiology department to have an X-ray, and it's difficult to check how stable the hip is. In an ideal scenario, it is better if we have it in a proper theater. But having said that, the sooner you reduce, the better it is. Reduction maneuver, normally it requires 2 people. There are 2 techniques, supine and prone. I'm not going to go more on that. I've always done the supine maneuver, but there is a prone maneuver also. The prone maneuver, I don't think it is the greatest maneuver, because you have to appreciate these patients have got other injuries. The anesthetist will start getting nervous if you have to put the patient prone, and so on and so forth. Okay, the advantage of prone position is it's a 1% technique and important, and it is a bit impractical in trauma patients. Okay, and the normal philosophy in the supine position is to flex the hip to 90 degrees, as we assuming majority of them are posterior dislocation, and give traction, and the hip will come back in position. Now, if you look at it, you can imagine there are various forms of pushing the hip, with one person stabilizing the anterior superior iliac spine or the pelvis, and the other person pulling it. You can also do traction if you want to. Majority of the times it will come by manual traction, but you certainly can do a traction, or you can put a Steinman pin into the hip joint. I've rarely done that, but it's possible you can do that too. So the most important thing is, after you have reduced the hip, you have to test for the stability of the hip, see how unstable the hip is. Sometimes, if the hip is unstable, you have to make sure that temporarily the hip remains in. So, whenever you have hip dislocation, you have to think in a very systematic manner. Sorry for being a broken record. The most important thing is to reduce the hip. Most important thing is to reduce the hip, but the most important thing comes before that is to make sure there are no associated other injuries. Okay? And once you have reduced the hip, you have to check for the stability of the hip to see whether the hip is inside or whether the hip comes out. The easiest thing to keep the hip reduced in is to make sure the knee is extended by putting a cricket splint or by putting a traction. Now, the stability of the hip can be checked in various factors. Now, one has to always appreciate the fact that posterior wall fractures is one thing which can cause problems. Definition, a virgin hip will always, or majority of the time, have a posterior wall dislocation, and hence the hip is not as stable as what one would want to. Now, this is important. How do you manage when the hip is an irreducible hip? And whenever, as a registrar, you have this in any, you have to always think about, it is not just pulling the hip. The hip might come back. The hip doesn't come back. What is your management protocol? And hence, a pre-op CT is very important to determine how the posterior wall is doing, how many fragments there are, and what are the associated injuries related to that. So I always ask my registrars or the front see if all the A&E staff, see if it could be reduced once. Repeated effects of the same thing not going to be successful, nor is it going to be helpful to the neurovascular structures or the articular cartilage. So, what you have to think in terms of a hip dislocation, once it has happened, a virgin hip, what are the secondary procedures? So, if the hip is stable, after reduction and the hip is congruent, you can wait and watch. In my practice, the majority of the time is once the hip is reduced, I would watch the patient like a hawk and review the patient regularly, limit the flexion of the hip about 60 degrees. I would early mobilize the patient. Weight bearing, if it's an elderly patient, it is difficult to touch weight bear them. I would normally weight bear them as pain allows, because you can tell the elderly patient to touch weight bear them. Normally, it never goes. The patient is bedridden. After that, gets deep vein thrombosis, gets a pulmonary embolism, and the conversation goes from there. But in a young patient, if possible, you should weight bear them for 4 to 6 weeks. Now, what are the indications for operative treatment? So, indication for operative treatment is an irreducible hip dislocation with a femoral neck fracture, incarceration of fragments or fragments are present inside the joint, or if it's incongruent, or an unstable hip after reduction. Now, number 1, number 2, and number 3 are quite obvious. You got do operative treatment. Hence, coming back to my statement, when you have a hip dislocation, if you are in a secondary setting, so in UK, the secondary setting or a primary setting is a general practice setting. A secondary setting is a district general hospital, which has got all the facilities except having a pelvic surgeon. You may or may not have. For example, I do everything in hips. I do pelvis also, but I work in, as I said previously, I work in between primary and a secondary. In between a secondary and a tertiary setting. And a tertiary setting is when you have an acetabular and a pelvic surgeon who is trained and have got their own on-call rota working. So, if you are seeing majority of us are working in a secondary setting, I'm fortunate enough to work in a secondary setting with more input on it. But when you're working in such a setting, it is important to understand. For example, you might not have a pelvic surgeon with you in your rota. It is quite crucial not to attempt to start operating on a patient if you are doing less than 10 operations a year in the acetabulum, and try to work around it. So any acetabular fractures associated with this, I would refer this to a tertiary referral center, because it is just a number game. Most of us can get into a hip joint, but reducing the posterior wall, fixing the posterior wall, if you don't do it on a regular basis, please don't do it. Please refer it to a tertiary referral center, provided the neurovascular structures are intact, or you have done the primary care to the patient, that is by reducing the hip and decreasing the pressure on the sciatic nerve. Because it is quite important to plan for this patient. What are the effects? Majority of them will come back in 10, 20 years' time with an arthritic hip. You really need to understand how do we plan the process of this patient, or the life or what is the life expectancy of the femoral head in this patient, and how do we plan the surgery. So if you have an irreducible hip, what are the approaches available? That is a Smith-Pearson's approach or a Watson-Jones approach, similar approach. And how do you placement of Steinman pin at the intertrochanteric region, manipulate the femoral head, repair the capsule if it's accomplished with further dissection. You have the Langenberg approach for the posterior. So it is the first one I said was for anterior dislocation. Second one was for the posterior dislocation. The Langenberg approach is a fantastic approach. You know, it lays open everything. You can repair pretty much everything you want to by that approach. I do about give or take about 900 to 1,000 operations a year. My elective practices is complex hip replacements and revision surgery, so I'm very comfortable doing posterior approaches. So Langenberg approach is not something which I worry about, but the anterior approach is not something which I use often enough. I use often to be comfortable with, but one has to always delineate which way one is going from an anatomy point of view, because it's quite crucial. When you have a patient with multiple trauma injury, what you want is a slick operation, reduce the hip, and be comfortable about the anatomy when you're going in. So when you have posterior dislocation with a large femoral head fracture, now this is when it gets into what I would say tiger territory, or when you have to be very crucial from the time point of view, the team around you, and how to do this. These are rare factors, and I normally probably would not see more than 1 or 2 a year. So you have to be bang, bang, bang. You need the right team, the right anesthetist, and to get on with it. So you have got 3 options. Is the easiest option I would start with is the GANS, tantric flip osteotomy, which makes it much more easier to reduce the fracture, to put it back in and stabilize the fracture, so on and so forth. The other fractures are detach the femoral head ligament, reduce the hip through a posterior incision, second option. The best option is, but whatever you do, it is quite important to appreciate that how do you preserve the blood supply to the femoral head, or decrease the amount of damage that can happen to the blood supply. Now, hip dislocation with a femoral neck fracture. One is always concerned about ADN, and you have to appreciate the fracture. The point, close reduction is not something which I would advise when you have a femoral neck fracture. And you have to appreciate the point that if you have a femoral neck fracture with hip dislocation, it's usually posterior dislocation. The posterior approach is much more easier to sort it out, to look at the bigger picture and sort it out with the hip dislocation, stabilize the neck of femur fracture. Now, incarcerated fragments, as I previously said, is much better if you have a CT. Appreciate if you have very small fragments, surgical removal is necessary to prevent abrasive wear of the cartilage, because what you don't want is small fragments or loose bodies around there, which causes further arthritis of the hip. Okay, it's very hard to know how much to remove, but you want to make sure that you have got a congruent hip at the end. Now, if you have femoral head fracture, or that is if you have an incongruent reduction, that is either there's an acetabular fracture at weight-bearing portion, or you have a femoral head fracture. The goal here is to achieve congruency. That is the most important thing you have to think about when you have an incongruent reduction. An incongruent reduction can cause problems, and mostly in adults, you can have the loose bodies removed arthroscopically. The benefit of arthroscopic reduction is a bit debatable. In my opinion, I would jury still out or not sure what is the right pattern of treatment. Now, this is one which you always have to worry about. Once you have reduced the hip is unstable, what do? Either it is due to a posterior wall problem, or if there is a labral detachment or a tear. The labral detachment is slightly uncommon. It is mostly because of a posterior wall or a femoral head fracture that it is unstable. Now, results of treatment, large range. You have to appreciate the point that irreducible hip dislocations are strongly associated with poor results. That is fundamentally what you need to let the patient and the family know about. Now, what are the complications of the hip dislocation? As we have suggested, the most important complication one has to worry is about avascular necrosis of the femoral head. And avascular necrosis of the femoral head is implied in majority of research that is available, that your risk of AVN increases as your surgical time delays, and hence I have previously suggested that it should be reduced as soon as possible. Some of the numbers that have relate is within 6 hours. There's a higher chance, a 20 times higher chance if the hip is not reduced. The research has come down a little bit on the numbers, but the most important point is to reduce the hip. But you have to appreciate the fact not to jump into treatment without knowing what are you going to do. It's always safe to see if you can closely reduce the hip. But if you are going to open the hip up, you should know what you are going to do if the hip is unstable. Post-traumatic osteoarthritis, I get a lot of this. This is, as a matter of fact, majority of my work is associated around post-traumatic osteoarthritis. It can occur because of AVN. It can occur because of several cartilaginous injury. It can occur because of femoral head or acetabular fractures. Now, recurrent dislocation, this is rare. I personally don't have a lot of experience on that. As a matter of fact, I might have seen 1 or 2 in Ehlers-Danlos syndrome, but not a lot. I can't say a lot about this because I have not seen this on a regular basis. You know, in Ehlers-Danlos syndrome, I have had patients who say that, oh, the hip comes out and comes in. I'm not entirely sure that I have got any visualization or X-rays or MRI scans to prove so. Now, recurrent dislocations can occur because of defect in the femoral head or the posterior wall. Now, delayed diagnosis. I have probably in my 20 years experience maybe had 1 or 2, and that too about not delayed, maybe 3 to 3 weeks, because they were ITU admissions, they were intubated. When they came out of intubation, they had a missed hip dislocations. The bottom line is that even if you see a delayed dislocation, you still need to reduce the hip. Imagine as if you are doing a shoulder dislocation, but shoulder dislocation and neglect. Shoulder dislocation can work. A hip dislocation, hip is a weight-bearing joint, and you can't do that. Sciatic nerve injury occurs in 20% of adults, 5% of pediatric patients with a hip dislocation. And peroneal nerve is affected, more common than tibial nerve, because as we previously said from the anatomy of the sciatic nerve, that is how it's affected. Nerve is stretched, compressed, or transected. Majority of the time it is neuropraxia. And about 40% of the time it's complete resolution if you have a nerve that has got neuropraxia on it. Now, if sciatic nerve does not improve within 3 to 4 weeks time, what are the options available? You do an EMG study to see what kind of nerve damage is there, and from there you can take on the process. It is important, as I previously suggested, that clear documentation of the neurovascular arrangement in terms of sensory and motor function of sciatic nerve is important, pre and post reduction, to appreciate what are the intervention that is required. Now, foot drop, if you have a foot drop after which you have seen before, once it is reduced, you can splint it and improve the gait, and which will prevent the contractures. Infections, if you have opened it up, it's about 1 to 5%. Antibiotics is required, the most important thing is to make sure that you have got joint stability. And iatrogenic sciatic nerve is most common, the posterior approach to the hip, and which might be because of prolonged retraction of the nerve. Iatrogenic sciatic nerve, prevention is by preventing hip in full extension or maintaining knee inflection, and avoid retraction in lesser sciatic nerve injuries. Now, it's very important to remember that majority of these patients will have multiple trauma injury, and when you have a multiple trauma injury, you have to think of embolism and DVT. This is where you will have to think whether the patient needs warfarin, low molecular weight heparin, whether the patient needs an IVC, inferior vena cava filter, and what kind of prevention the patient needs for 6 months to make sure the patient does not die of a DVT. Now, this is primarily to do with virgin hips. Now, as far as when you have a hip which has got a hip replacement, which has dislocated, I'm just going to say one sentence, apologies for using more of my time, is that always think about patient factors, instrumentation factors, and surgeon factors. And from there, you have to decide which way you have to intervene when you have a hip replacement. Thank you very much, and sincere apologies if I have run out of time.
Thank you so much, Mr. Unnithan, for this very comprehensive presentation. Thank you, sir.
Any questions? How does it work normally?
Yeah, it's an excellent presentation, sir. Mr. Ahmed Sheikh from UK will be the moderator with you, sir. Waiting for any questions. Dr. Ahmed?
Can I have a question?
Professor Bahad, yes, please go on.
Yes, thank you for your nice presentation. Just I wanted to concern, if you have a reducible hip, it is better to do a CT or MRI, because you mentioned that you are going to do CT. But sometimes a reducible hip can be due to soft tissues like piriforms, like muscles, or capsular herniations, something like that. So which one modalities you prefer to do it?
So I thank you. So thank you for the question. So I normally prefer CT, and the simple reason is in my hospital, CT is faster to obtain. But given an opportunity, I will have CT and MRI scan.
I see.
Following that question regarding the MRI, because you mentioned that the main concern about MRI is to have a bottom line MRI to be compared with any future MRI. So apart from the emergent situation when the hip is dislocated after dislocation, would you still request MRI on maybe after a week or two to have this bottom line MRI for further follow-up after 6 months or 12 months or so?
Very good question. Yes, always by definition, I will have an MRI after the hip is reduced. As a baseline investigation. It is not necessary. Literature is not clear on that. But this is my personal practice. In my personal practice, I'll always have an MRI before and after. Simple reason is that if the patient comes back at 3 months or 6 weeks, there's a possibility there on the stir sequence. There's a lot of inflammation. There's a lot of edema in the bone. So one does not know what is new, what is old, and simply for that reason, I will request an MRI scan.
Yeah. Regarding the same point, the CT, just one of our colleagues asking, before the reduction of the dislocation or after the reduction? So do you request 2 CTs or just one after the reduction?
No, so I will always have a CT before the reduction. Now, based on the fact, if there is a posterior wall fracture which has got several fragments, I will always have a CT afterwards to make sure that the hip is congruent. For thoroughness of the practice, I will always have a pre and a post CT.
Perfect. And after the reduction, regarding the traction, a question about skin or skeletal traction.
So in my practice, majority of the times I can get away by doing a skin traction or by putting a cricket bat splint, that is to make sure the knee is not flexed. I rarely put a bony traction or a hip after the hip is reduced, because if you have to put a bony traction, that simply means that the hip is too unstable and you need to go primarily in and to fix it back.
Okay. A complex situation when you have a pelvic ring fracture with a dislocation, how would you address the pelvic ring first or the dislocation first?
I will always reduce the fracture first and to decrease the pressure on the sciatic nerve and then address the pelvic ring. So as I said to you, I am primarily not a pelvic surgeon, and majority of us are not pelvic surgeons. So I would reduce the hip, make sure the neuropraxia or the sciatic nerve pressure is decreased, and then and then refer appropriately if the pelvic ring has to be addressed.
Okay. One of our colleagues from Iraq asked about, did the classification mentioned describe floating hip in associated pelvic and femoral fractures?
No, I have not mentioned that aspect of it. A floating hip, to be honest with you, it's very rare, and probably the panel will have more experience than me. I really do not have an experience of a floating hip, so that's why I didn't mention that.
No, that's fine. Regarding sciatic nerve palsy, I have a question myself. Regarding the bottom line investigation, would you go for EMG nerve conduction velocity after the patient stabilized, maybe after a week or so, just to calculate the bottom line sciatic nerve, also for further
So that is a very good question. The problem I have, so in my opinion, the MRI with a very good radiologist will give you a very good idea of the sciatic nerve problem from initially. The EMG study done initially, it really, you certainly can do an EMG study initially, but in my opinion, I have not got a lot of information from an EMG study done immediately after the hip has been reduced, and I think the results are quite checkered on that.
Thank you so much, Mr. Unnithan, for this very fruitful and interesting presentation. Hoping to see you again and again with us in the course, sir. Thank you so much, and Merry Christmas.
Thank you so much for having me here. Thank you. Merry Christmas.
Thank you so much, sir.